Hello friends, today's topic of discussion is neuroprognostication. So neuroprognostication after cardiac arrest, about 80% of patients who are resuscitated from the cardiac arrest are comatose due to post-cardiac arrest brain injury, and most of them will die or have some severe neurological disability. So predicting neurological outcome after cardiac arrest is important both to provide correct information to patient's relative and to avoid disproportionate care in patients with severe and irreversible post-cardiac arrest brain injury who have no chance to achieve neurologically meaningful survival. Now, the major predictors of the neurological outcome. Clinical examination. Clinical examination is the central to the neurological prognostication in post-cardiac arrest brain injury. Even before sedation is finally discontinued, performing clinical examination daily is recommended to detect the signs of consciousness and to identify the sign that brain death has occurred. So the most used clinical prognostic examination sign are motor response, ocular reflexes, and myoclonus. Presence of absence and the stereotypic flexion or extensive response to pain, that is a Glasgow scale of motor component less than or equal to 3 at more than or equal to 72 hours after ROSC, is relatively non-specific but very sensitive sign of poor neurological outcome and is recommended as an entry point for prognostication algorithm. Previous guideline recommended as GCA score with the M less than or equal to 2 as an entry. So ocular reflexes are generated in the brainstem, which is relatively resistant to anoxic injury, so that their persistent absence is more specific sign of the severe post-cardiac arrest brain injury than an altered motor response, which may be generated on different level from cortex to the brainstem. At more than or equal to 72 hours after ROSC, bilaterally absent pupillary or corneal reflex predict poor neurological outcome with uh, with FPR of less than 5%. Unlike the corneal reflex, the pupillary reflex to light is more accurate and it is not affected by muscle relaxation. However, rare cases of reversible unreactive mydriasis have been reported in COVID-19 patients with acute respiratory distress syndrome treated with the prolonged infusion of rocuronium. Standard passive leg raise is the operator dependent and its accuracy is reduced with the uh, the standard pupillary right reflex is operator dependent and its accuracy is reduced when pupil size is less than 2 mm. Conversely, the quantitative automated pupillometry is accurate even when pupil size is very small and it is reproducible. Neurological pupil index is the combined index including parameter derived from quantitative pupillometry such as size, constrictive percentage, and constriction and dilation velocity and latency, and can accurately predict the poor neurological outcome as early as 24 hours from ROSC and is preferable over standard pupillary light reflex. Myoclonus consists of sudden brief involuntary jerks caused by muscular contraction or inhibition. Appearance of myoclonus is very often but not consistently associated with poor neurological outcome after cardiac arrest. So some characteristic of the myoclonus such as early, that is less than 48-hour occurrence, a generalized versus focal distribution, a synchronous or a stereotype pattern, and prolonged, that is more than 30-minute duration, that is status myoclonus, are associated with worse outcome. With presence of continuous or reactive EEG background as opposed to the burst suppression is associated with the more favorable outcome. A special form of post-anoxic myoclonus is Lance-Adams syndrome. This is a form of action myoclonus appearing during voluntary movement of the limbs. Patients with the Lance-Adams syndrome generally achieve neurological recovery even if myoclonus may become chronic or cause disability. Although Lance-Adams syndrome appearance is associated with awakening, myoclonic movement can be so intense to mask the presence of consciousness. In this case, EEG recording may help distinguish Lance-Adams syndrome from more malignant form of myoclonus. The next is biomarkers. Several components of the neurons and the glia cells can measured in the serum or plasma after cardiac arrest as a marker of post-cardiac arrest brain injury. Major advantage of blood biomarkers are that they are easy to obtain and offer quantitative and easily interpreted measures of the extent of brain injury. Disadvantage are the variability and the lack of analytical standard, complicating comparison between the studies using different assays and instruments. Focal lesion due to stroke and trauma should always be excluded by appropriate imaging when interpreting elevated levels of any brain biomarker. In addition, extracerebral sources exist for all biomarkers, albeit to varying extent. Neuron-specific enolase is the best documented and most widely available marker of post-cardiac arrest brain injury. As such, is the only blood biomarker recommended for prognostication after cardiac arrest. NSC levels increases and peak at 48 to 72 hours after arrest in poor outcome patients. The current recommended cutoff for reliable prediction of poor outcome is 60 mg at 48 to 72 hours, which is consistently higher compared to earlier guidance. Normal neuron-specific enolase of less than 70 mg predict the good outcome. NSA is present in the blood cell, and given that half-life of free hemoglobin, that is 2 to 4 hours, is considerably shorter than the half-life of the NSA. Hemolysis, for example, due to CPR or intra-aortic pump must be considered also when no longer detectable. Serial measurements are recommended and high but rapidly decreasing level, typically by 50% or more, in 24 to 48 hours should be considered a sign of hemolysis. Then next is neurofilament light chain. It is a cytoskeletal component of the large myelinated axon of central and the peripheral nervous system, and increased blood level correlate with the severity of several neurological disorders, including stroke, amyotrophic lateral sclerosis, and dementia. A limited number of studies using the highly sensitive SIMOA technology indicate that neurofilament light chain has a superior prognostic performance compared to the other biomarkers and also the other available methods. In recent study investigating the ability of the six biomarker to predict the good neurological outcome after arrest, the NFL was most consistent predictor, having the second best sensitivity and specificity. While NFL is the gradually being introduced into clinical practice for other diagnoses, such as development and the validation is necessary before it can become standard assay for post-cardiac arrest prevention. Next is electrophysiology, short latency somatosensory evoked potential, that is SSP. SSEPs of the upper limb are elicited by stimulation of the median nerve at rest, and resulting ascending potential are recorded at plexus brachialis, posterior cervical level, and contralateral sensory cortex. Negative wave recorded at around 20 ms on scalp is terminated as N20, and it reflects the activation of primary sensory cortex. SSCP are resistant to hypothermia and neurodepressant drugs. The bilaterally absent cortical N20 wave after cardiac arrest almost invariably indicates severe post-cardiac arrest brain injury, even if false positive results have occasionally been reported. In some instances, the N20 was not detected due to artifact, correct, uh, uh, which is prevented a correct reading of SSEP trace. One of the major source of artifact is the muscle activity, which can be removed by muscle relaxant. Use of the muscle relaxant is recommended when recording SSEP for prognostic purposes. Unlike EEG, bilaterally absent N20 wave can yield 100% specificity as early as 12 hours after cardiac arrest. However, its sensitivity is low, often not exceeding 40%. Recent evidences have shown that not only an absent N20, but also the present but low amplitude N20 wave predict poor neurological outcome as well and increasing sensitivity. Now, this is the diagrammatic representation of a normal short latency somatosensory evoked potential pattern after stimulation of right median nerve at rest in patient with a good outcome after cardiac arrest. N20 wave is recorded on the contralateral scalp area corresponding to the somatosensory cortex. EEG, the now next is EEG. EEG is the most widely used test for assessing the severity of post-cardiac arrest brain injury in clinical practice. However, its interpretation is complex and prone to subjectivity. In 2012, the standardized terminology for EEG in critical care patient was proposed by American Clinical Neurophysiological Society. The three main aspects to consider when using EEG for prognostication are background activity, presence of superimposed discharges, and the reactivity to stimulation. In patients with the post-cardiac brain injury, lack of continuity and the low amplitude of EEG background are associated with worse outcome than continuous and normal amplitude pattern. When all amplitudes of EEG are recording below 10, the term suppression is used. Although EEG may be transiently suppressed after ROSC in patients who subsequently recover, the persistence of suppression after 24 hours is almost consistently associated with unfavorable outcome. A suppressed EEG background alternating with a burst of electrical activity lasting less than 50% of tracing is defined as burst suppression. As occurred for suppression, the accuracy of the burst suppression or prediction of poor neurological outcome is higher after 24 hours from ROS. There is substantial inter-rater agreement among experienced neurophysiologists for detection of VS in recent for detection of burst suppression. In recent studies, the suppression and burst suppression have been combined to define malignant background pattern. So ACNS has identified specific subtypes of the burst suppression or specific prognostic interest in post-cardiac arrest brain injury. Burst suppression with the identical burst is a burst suppression where first zero point 0.5 second or more of each burst and each stereotype cluster of two or more bursts appear visually similar. Highly epileptiform bursts are present if more than 50% of bursts, including epileptiform discharges or rhythmic activity. In multi-centered European study on 850 patients, both these subtypes predicted poor neurological outcome at 6 months with 100% specificity as early as 6 hours after ROS. Presence of electrographic seizure superimposed on EEG background also portend poor neurological outcome in post-cardiac arrest brain injury. This is particularly true when seizure occur early during first 12 to 24 hours from ROFC or are associated with other unfavorable features such as unreactive or suppressed EEG background. ACNS defines unequivocal seizure as generalized rhythmic spike and wave discharge with frequency of more than 3 Hz or clearly evolving discharges of any type of more than 4 Hz. The definition has been inconsistently used in the prognostication studies. The term status epilepticus is used to indicate presence of continuous and persistent seizure. The 2021 update of ACNS terminology standardizes the definition of electrographic status epilepticus as electrographic seizure lasting for more than or equal to 10 minutes or for duration of more than or equal to 20% in 60-minute recording. However, definition used in pre-2021 literature are inconsistent, and for that reason, the 2021 guidelines on post-resuscitation care did not recommend using term status epilepticus for prognostication until sufficient evidence using standardized definition will be available. EEG background reactivity consists of measured changes in amplitude or frequency when stimulus is applied. The method of stimulation or assessment of reactivity vary widely, and only recently an expert consequences proposed standardization of both stimulus type, repetition, and duration. This variability has probably contributed to inconsistent accuracy of EEG reactivity as prognostic test in the literature. Presence of EEG reactivity is nevertheless a sign of good neurological outcome, while its absence has little added value to EEG background. Now, these are the examples of EEG pattern after cardiac arrest and are classified as highly malignant. A diagram A is indicative of suppression without discharges. B is indicative of suppression with continuous discharges, and C is the indicative of the burst suppression. So the next is imaging. So brain CT is extensively used shortly after cardiac arrest to rule out neurological causes of arrest, especially intracranial hemorrhage, which could contraindicate percutaneous coronary intervention. However, CT also allows assessing the severity of the post-cardiac arrest brain injury by detecting brain edema. CT signs of the vasogenic edema include sulcal effacement and the reduced cerebral ventricle size. A pseudo-subarachnoid size caused by the venous engorgement of cerebral sinuses may also be observed. On brain CT, the neuronal swelling from cytotoxic edema resulting in decreased density of the gray matter, while the white matter remains relatively unaffected, so that density ratio between the gray and white matter decreases, and gray-white matter interface becomes less visible. Several studies assess the prognostic value of the decreased gray-white matter ratio measured in specific region of the interest within the basal ganglia or cerebellum. The gray-white ratio threshold for prediction of the poor outcome with 100% specificity varied widely. In recent systematic analysis, the reported threshold for average gray-white ratio between basal ganglia and cerebrum range from the 1.07 to 1.23. Reason for this variability included differences in sampling areas, the scanner software, and hardware. In a multi-center study on 356 post-cardiac arrest comatose patients, visual non-quantitative assessment of edema on CT brain performed by experienced neuroradiologists was also accurate in predicting poor outcome after cardiac arrest. Cytotoxic edema on magnetic resonance imaging appear as an hyperintensity on diffusion weighted imaging with corresponding hypoattenuation on apparent diffusion coefficient values. This apparent diffusion coefficient allows quantitative measurement of restricted diffusion on brain MRI, and several studies have identified or validated ADC threshold below which poor outcome can be predicted with 100% specificity. However, as for a gray-white ratio, these thresholds vary widely across study due to differences in measurement technique, brain region studies, and timing of imaging. Regarding timing, although brain CT can show signs of severe post-cardiac arrest brain injury less than 1 hour after ROSC, limited evidence shows that in some patients these signs appear 2 to 6 days later, suggesting that performing later or serial CT scan may increase its sensitivity for prediction of the poor outcome. For MRI, signs of the altered diffusion are more prominent in basal ganglia during first 3 days after ROSC, followed by cortex and the subcortical white matter. Currently, there is no definite consensus on optimal timing of imaging studies as prognostication after cardiac arrest. These CT images shows these are the CT imaging showing like picture A showing normal brain from 70-year-old man, and B showing CT brain of 40-hour post cardiac arrest in 48-hour old man. So we can note the generalized edema with sulcal effacement, ventricular narrowing, and reduction of the gray-white matter differentiation. So this is the neuroimaging of the hypoxic ischemic brain injury after cardiac arrest. Two patients are presented with the magnetic resonance imaging sequence pertaining to the diffusion weighted imaging in patient. The patient one, the restricted diffusion is demonstrated throughout the entire cortex, depicted by hypoattenuation. Conversely, the patient two demonstrate no restriction, depicted by the normal attenuation on diffusion imaging, and the corresponding head computed scan also shown. For patient 1, the diffuse loss of gray-white matter differentiation is demonstrated, and for patient 2, it is preserved. Now we'll see the ERC ESICM 2021 algorithm for prognostication. The 2021 guideline for on prognostic post-resuscitation care, the European Resuscitation Council and the European Society of Intensive Care Medicine suggested prognostication strategy in adult who are comatose after resuscitation from cardiac arrest. And the key elements of that strategy are Clinical neurological examination is central to the prognostication. Therefore, prognostic balance can be made only after confounding from residual sedation and neuromuscular blocking drug that has been excluded. No predictor is 100% accurate. Therefore, prognostic judgment cannot be based on the single predictor. Recent evidence shows that combining two or more tests for the poor neurological outcome minimizes the risk of falsely pessimistic prediction. 2021 guideline introduces the principle of concordance among the test results. Two or more concurrent unfavorable test results are required to prognosticate poor neurological outcome, while in case of discordance between the test indicating poor prognosis and other indicating good prognosis, a prognostic reassessment is recommended. Signs indicating potentially good outcome include early return of favorable EEG background, that is continuous reactive and without epileptiform activity, low blood level of NSC within 72 hours from ROSC, and absence of diffusion changes on brain MRI. 2021 guideline introduces the principle of concordant ones among the test results. Two or more concordant unfavorable test results are required to prognosticate poor neurological outcome, while in case of discordance between the test indicating poor prognosis and other indicating good prognosis, a prognostic reassessment is recommended. Noko. Signs indicating potentially good outcome include early return of favorable EEG background, that is continuous reactive or without epileptiform activity, low blood level of NSC within 72 hours from ROSC, and absence of diffusion changes on the brain. In a comatose resuscitated patient who after at least 72 hours after from ROSC and exclusion of compounder has motor response to pain no better than stereotypic posturing. Poor prognosis is predicted when two or more of the following are present. Like this is a very important table in which targeted temperature management and rewarming. So unconscious patient with the M less than or equal to 3 at more than or equal to 72 hours without confounder, at least 2, that is no pupillary and corneal reflex at more than 72 hours, bilaterally absent N20 SSEP wave, highly malignant EEG at more than 24 hours, NSE more than 60 microgram per liter at 48 and 72 hours, status myoclonus less than 72 hours, diffuse and extensive anoxic injury on CT, brain and MRI. If at least two of these six component is present, then yes, the prognosis will be poor. And if it is not, then we need to observe and reevaluate. Now, the prediction of the good neurological outcome. Most of the available evidences on prognostication after cardiac arrest is based on the prediction of the poor neurological outcome. Consequently, the current algorithm provided limited prognostic guidance in the population of patients lacking major unfavorable sign and whose outcome remains indeterminate. The ESICM 2021 guidelines suggest caution in the reassessment when predictors of the poor outcome coexist with signs indicating potential for recovery. These signs include benign EEG, that is continuous reactive non-suppressed background without epileptiform discharge, absence of diffuse changes on brain MRI, low levels of biomarkers. However, there are no current recommended strategies to predict good neurological outcome after cardiac arrest. Thank you.